Dr. Tawfiq.
Start, doctor. Started. You can start.
Good evening, ladies and gentlemen. On behalf of my colleagues, the organizing committee of Dubai Pediatric Club, I would like to welcome all viewers from Dubai, UAE, GCC countries, India, United States, and all countries across the globe to this webinar. This webinar is conducted in collaboration with NMC Specialty Hospital Dubai and is sponsored by Vita Biotics UAE. I would like to thank the country business manager of this company, Dr. Tawfiq Ali, who is always with us. Well, tonight's webinar, the topic is applications of artificial intelligence in medicine and in particular in pediatric practice. We have eminent speakers and panelists and well-known moderators. In a short while, I'll be introducing them. Well, always I start with the question. Those who answer the question, Dr. Tawfiq will announce the name and a token of appreciation will be given to the winner. Well, who are these scientists? You just tell us who are these scientists and what is their contribution. Beautiful Dubai, as usual. Beautiful view of Sheikh Zayed Road day and night. Those who have not seen, I would like to request them to come and see this beautiful city. Well, as I said, today's topic is about artificial intelligence in medicine and pediatric. We have eminent speakers well known to all of you. Dr. Anurag Bajpai, Senior Consultant Pediatric Endocrinologist from Regency Kanpur, India. He is very well known to all of you. He is world famous, not only based in India, Asia, and beyond. We have Dr. Asrar Rashid, Senior Consultant Pediatric Intensivist at NMC Royal Hospital, Abu Dhabi, UAE. He is also very well known to all in UAE. I'll be chairing the session. We have moderators, Dr. Kalpana Sengupta, Senior Consultant Pediatrician, Head of Department of Pediatrics at NMC Specialty Hospital, Dubai, and Dr. Diari Muhammad, Senior Consultant Pediatric Surgeon at Al Jalila Children's Hospital, Dubai, and is the chairman of the academic affairs. We have with us Engineer Rachid Sengupta, Senior Software Engineer working as an applied artificial intelligence team at Intuit, San Diego, United States. He'll be joining us as a panelist tonight. Well, on behalf of all members of Dubai Pediatric Club, seen here in the 9th and 10th annual conference, and on behalf of the organizing committee, who are very well known to all of you, I would like to welcome all of you once again to this webinar. Well, I would like to bring to the notice of our viewers that our 10th annual DPC Symposium will be held on Friday, 22nd November 2024 at Swiss Hotel Al Marouj Hotel, Sheikh Zayed Road, Dubai. Please save the date, the 10th annual DPC Symposium, 22nd November. So please save the date. Well, our organizer, Dr. Tawfiq Ali, Senior Country Business Manager of Vita Biotic and New Country Health, very well known to all. Well, briefly, in few slides, I would like to give a brief account of artificial intelligence. Well, always I start the memory of Hippocrates, the father of medicine, Al-Razi, the father of pediatrics. Well, now we stop getting the answers from the viewers. John McCarthy, computer scientist known by many as the father of artificial intelligence. John McCarthy, an American computer scientist, pioneer, and inventor, was known as the father of artificial intelligence. The cognitive scientist coined the term in his 1955 proposal for 1956 Dartmouth Conference, the first artificial intelligence conference. Well, about the discipline of artificial intelligence, McCarthy, as I mentioned, founded the discipline of artificial intelligence. McCarthy's work, along with colleagues like Marvin Minsky and Alan Turing, who is also considered by some as the father of artificial intelligence, helped establish artificial intelligence as a distinct research area within computer science. So remember them. Well, about Alan Turing, as I said, Alan Turing, also known as the father of artificial intelligence, computer science, and cryptography. Cryptography means the when a message is sent, only the person who is supposed to see can read. Others, they cannot. This is called cryptography. Turing spoke of artificial intelligence in his seminal paper, Can Machines Think? To set a scale for measuring if an artificial being is intelligent, he proposed an imitation gear, which is very well known today as Turing test. You can go and see Turing tests. Well, about artificial intelligence in medicine, in one slide briefly, the initial effort in AI and its application in medicine began in early 60s, which focused mainly on diagnosis and therapy. The best known early works on AI in medicine include Stanford's TED. TED is a nickname, is Edward Shortleaf, and his innovative program called MySyn. What is MySyn? MySyn was a rule-based expert system that recommended selection of antibiotics for various infectious diseases. Interestingly, MySyn was proved to be superior to human infectious disease experts. And Professor Peter Solovitz is known as the father of artificial intelligence in medicine, edited the textbook of artificial intelligence in medicine in 1982 with a collection of papers on various topics. So he's the father of artificial intelligence in medicine. Well, about artificial intelligence in pediatric, artificial intelligence has a strong presence in the field of pediatrics. It can be useful in different areas, ranging from the detection of autism to prediction of the outcome of an orthokeratology, means the changing the diameter of cornea, treatment in pediatric. It is also used in newborn for jaundice, in endocrinology for bone age, so many in all fields of medicine. Well, there is an article just recently published on March. I'm sure Dr. Anurag also will mention. I'm not going to detail of that, which that this article examined the AI in the field of pediatric care within the framework 7P. They're analyzing it, this review article in 7Ps. What are the 7Ps? Predictive, preventive, personalized, precise, participatory, peripheral, and polyprofessional. Details, I'm not going to read this. Those who are interested, they can go to it. It highlights various applications of AI in diagnosis, treatment, and management of pediatric diagnosis. Please note that artificial intelligence is revolutionizing society at large and has great potential for significantly improving pediatric care. Well, now, this I'm not going, but this shows that in the field of medicine, radiology has maximum publications, followed by hematology, preventive medicine, pharmacology. This green is pediatrics. And pediatric publication is increasing. You imagine here in 2000, it was 7 publication, and now is more than 1,000. See the importance of AI in medicine and pediatrics. And these are those 7. I'm not going to detail of that, those who are interested. Well, about the speakers, as I mentioned, our speakers today, Dr. Anurag Vajpayee, Senior Consultant, Pediatric Endocrinologist at Regency Kanpur, India. Dr. Asra Rashid, sorry, Senior Consultant Pediatric Intensivist at NMC Royal Hospital, Abu Dhabi. We have moderators Dr. Kalpana Sengupta and Dr. Diari Muhammad, and our panelist is Engineer Rachit Sengupta. Mr. Sengupta is the son of Dr. Kalpana, who is a senior computer AI specialist at Intuit, San Diego, United States. He's kind enough to join us today in the panel. Well, details of the profile of the speakers have been sent. I'm not going to detail of that. As I said about Dr. Anwar, very well known, Dr. Asrar, very well known to all, and Mr. Sengupta, Rachid Sengupta, that he's a senior software engineer at Intuit San Diego, United States, and currently he's a part of the applied AI team in this company and is attending different conferences. Also, my references, beautiful Dubai. Those who have not seen, come and see. Thank you very much. Now I would like to request Dr. Anurag to please join and start. First, I would like to request Dr. Asrar. I would like to request Dr. Asrar to come and present. Then we will follow with Dr. Anurag. Thank you very much. Over to Dr. Asrar, please.
Okay. Good
Dr.
evening.
Asrar, thank you very much. Please start.
Thank you very much. I'll just share my screen and just share the, hope you can see that. Good.
Yes, please. Full screen, please.
Thank you. Thank you, Dr. Sharab. Thank you, DPC. Thank you, DPC and all DPC members and Mr. Tawfiq from Biotics for inviting me today. I'm a pediatric intensivist, but I'm also the chair for health informatics and digitization for NMC Group. I stumbled into artificial intelligence a few years ago when I was doing I'm in the process of completing my PhD, and it's been an aspect of my and so very grateful to be able to come and talk about a very exciting topic. This is Augusta Ada King, Countess of Lovelace, who was an English mathematician and daughter of the poet Lord Byron. She is referred to as the first programmer and probably and suggested as she wrote the first algorithm for machines in the 1800s. She was unusual for a time, training in mathematics as a lady, and this was very much in part because of the encouragement of her mother. Artificial intelligence is a contrast to statistics. Statistics, I think everybody will know, you need a certain framework to be able to work from, to have a hypothesis, and then to prove or disapprove the hypothesis. In machine learning, the contrast is that you just give the machine data and you give it potentially some rules and you expect it to discern patterns according to those rules. So you don't really need to know the framework. Machine learning, where the machine is taught and then it doesn't program, you don't program it anymore, it just learns to do these tasks, is a branch of artificial intelligence. Machine learning can be considered almost as a modeling technique, which helps find patterns from data, allowing you to categorize and also predict certain things. The different branches of machine learning. If you use labeled data, it's called supervised learning with labeled data. With unlabeled data, it's unsupervised, and then you have a semi-supervised level as well. There's something called deep learning, which basically is modeled around the brain's multi-level neural network, and there are other forms of learning also. Now we're going to dive into some use cases of machine learning, artificial intelligence applied to pediatrics. And there's going to be a theme. In fact, there's a theme in artificial intelligence which you'll find as we go through different studies. One of the challenges we have as pediatricians is to understand whether a chest X-ray that we see is one that shows infection or not infection. And this requires a radiological interpretation, which is dependent upon the experience of the clinician. The X-rays themselves can be interpreted by junior team members as well, but there is a certain level of subjectivity.
Dr. Asrar, sorry, there are a lot of echoes, Dr. Asrar.
Can you hear me now? I'm sorry. It's the room. I'm sorry. Maybe I can't do anything about that.
There is some interruption.
If you're near the mic, Dr. Asrar.
Okay, is that better?
Yes, yes.
Perfect. Thank you very much for that. So the work by Sarah Dominguez Rodriguez looked at the area of applying chest X-ray analysis in pediatrics. They used something called a convolutional neural network, which is used in interpreting medical images using machine learning. The research involved the CNN model, and it involved using large data sets from pediatric chest X-rays. First, they trained the data, then they validated data, and then they tested the data. This is a usual routine in artificial intelligence studies. This is what a convolutional neural network looks like. You have on the left side, you can see we have a pixelation from the picture that goes into the input of the algorithm, the artificial neural network. Then the data is modeled through multiple layers of hidden layers. And then you finally leads out to the output layer. In the output layer, you come up with the classification or the prediction as required. So in this case, the prediction would be that this is a bird or specifically a falcon. So convolutional neural networks often used in picture analysis. So how did we do the study? How did Sarah Dominguez do the study? First of all, the plan was to compare normal intelligence, highly intelligent doctors against a machine, an artificial machine. And if there was agreement, that was called true positive. If there was a disagreement, it's called false positive. Similarly, if the doctor and machine agreed that there was a true negative X-ray, then it's a true negative. However, if there was a disagreement, this is deemed as a false negative. So this is the prediction. You can see here that the true positives, false positives, true negatives, false negatives on the lower line. And basically, you can see there's differentiating two groups. The group on the left is the pneumonia group, and the group at the bottom on the right is the not pneumonia group. So how do they fare? You can see that the true positive group, the cases actually doing very well. The predictive probability of consolidation is high in these cases, indicating strong agreement. False positive, though, there was a disagreement, and the machine did make there were some disagreements. What's the clinical relevance of this? Well, understanding these discrepancies is important to improve the AI model's accuracy. And the goal is to minimize the false positives and the false negatives. If we can do that, that will be a good utilization of the model. How did the modeling fare with respect to different etiologies? Well, if you look on this, you can see this figure on the left, the true positives, that's actually very, very good. It shows that for a lot of the bacterial group, the model was very, very good. But unfortunately, in the false positives, you can see that there are the viral etiologies and atypicals. Now, for us, atypicals are extremely important because we need to make sure we treat all those with relevant antibiotics. So what we need to do is we need to really minimize that. And this is the plan for a lot of these AI models. They will see how it's working in real life and undertake more and more learning to improve the model, but not doing too bad. So these were the key observations. The AI system was effective, as I mentioned, in diagnosing typical bacterial infection, which means that which is crucial for timely antibiotic treatment. So if you can use the model and it can do the diagnosis quickly, that's actually very, very good for us as pediatricians. But we still need to work on the other aspects of the model. The conclusion is that the AI system exhibited high sensitivity and specificity, indicating that of pneumonia. It was able to differentiate some of the conditions. There's still a level of subjectivity, and depending on the radiological expertise, but there's a consistency provided by the system. The AI tool can accurately identify areas of infection and probably do so within minutes. So what does this mean for us? Well, it means we can have an improved workflow. It means also we can also teach doctors as well, trainees, in terms of using the tool and understanding, and in time, hopefully, be able to differentiate the etiologies. Now moving on to another area, tumor diagnosis and management. Can we use AI in the arena of oncology? And if we can do so, can it help us to detect the tumors and also do so to classify the tumors, and hopefully in a faster and more accurate way? Juan and others applied this deep learning model for posterior fossa tumors. Deep learning, as I mentioned, is a multi-layered neural network. So you have the input layer, and then you have multiple layers of what we call the hidden layer coming up with the output. And the output is cancer or not cancer, or classification of tumor type. You can see here, we're looking at 4 types of tumors, specifically. The diffuse midline glioma, DMG, medulloblastoma, MB, pilocytic astrocytoma, PA, and epidenoma, EP. These tumors are common in children, and early detection is crucial for effective treatment. The cohort consisted of 617 patients from 5 institutions and was compared against 199 control subjects. The MRI imaging used were the T2 weighted images, and data augmentation was undertaken to make the data more generalizable across the different data sets. As I mentioned, a deep learning architecture was utilized. And again, like we said in the previous study, you do the training, the validation, and then the testing. And from there, you can see how well your model that you're using, how well that fares. So this is very, very interesting. This is what the model does. You can see here on the top left-hand corner is the radiologist, a radiologist's interpretation of where they think the tumor is and what type of tumor. On the right is the heat map generated by the computer, by the machine learning system. And you can see here, it's actually doing very well. There's 95% prediction of the tumor and the fact that it's an astrocytoma. But the prediction in this case, in other cases, is not so good. You can see there on the lower panel, there is the heat map isn't so good because it's not able to pick that up. Similarly, another case of medulloblastoma, you can see here that 84% prediction, but unfortunately, still similarly also having other issues. It's not always good, as I mentioned. You can see here that it's mixing up the pilocytic astrocytoma with the DMG, and the heat map is all over the place. And finally, the same again. So this is one of the problems of machine learning algorithms. When you start using them, there are difficulties. So you need to develop the system, the model, to improve the outcome. With machine learning, there's a lot of data that's put into the system. As I said, you don't need to know how the data looks like. You just need to put that in, make some rules. But the machine also needs to be able to work out which bits of data are important. And there are various ways of doing this. These are called data reduction techniques used in artificial intelligence. On the left is primary component analysis, and on the right is t-SNE plots. You can see here on the left, you can see it's the blue, which is DMG, differentiates quite nicely, and the red, the PAs, and the green, the medulloblastoma, kind of merge together. Similarly, on the t-SNE, you can see here that there is differentiation of the blue and the green, which is really very helpful when you're trying to classify such tumors. So the key points here is the AI model can help differentiate the DMG tumors. The PAMB, there was overlap, but it was distinguishable. The EP was unfortunately was challenging. How does this compare to radiologists? So these are all board certified radiologists. You can see here, actually, the sensitivity and specificity is a bit better. So very valuable model in this scenario. The strengths of such a model is that it's generalizable across 5 different institutions, and it was independent of the MRI machine used. Yes, it was limited because we were just concentrating on T2 scans and only looking at a few tumor types. But wouldn't it be amazing if we could pick up more and more tumors? And this is what the researchers want to do in the future. Artificial intelligence is not just about classification. Here you can see on the right a PET scan using a dye test, high dose FDGB imaging medication. But using artificial intelligence, it's actually possible to use a lot lower dosing, which is also good. So you can see artificial intelligence has the opportunity to affect many aspects of oncology. It can improve diagnosis, screening, enhance detection and classification. May also be vital in personalized therapy planning and optimizing workflows. So we've spoken a little bit briefly about a couple of use cases, but there's also value in utilization for other aspects such as antimicrobial resistance. And it's always difficult following Dr. Shorab, but he kindly did mention its use utilization in antibiotic prescribing. AI in prescribing can be valuable in terms of analyzing patient data and offering early diagnosis and management with respect to infections. Tools can help differentiate infectious and non-infectious causes. AI systems can help improve antibiotic prescribing by learning new rules and adapting to changing data. It can also help predict antibiotic resistance in institutions, aiding physicians in selecting the correct antibiotics. pharmaceutical industry can also have value from such a tool in terms of helping to identify new medications, medications that potentially vital in reducing risk of resistance. They may also be useful in providing discovery of new antibiotics and reducing the time for development and time costs. If you recall the Moderna vaccine, the length of the messenger RNA, multiple lengths of messenger RNA were analyzed by the Moderna team. Using artificial intelligence, they were able in 2 days to pinpoint a couple of strands of messenger RNA that were vital to the development of a vaccine. As pediatricians, we're dealing often with asthma. Now, wouldn't it be amazing if we could help utilize AI to help control asthma better? Better compliance and less asthma episodes should be the gold standard. This is a study by a team at Mayo Clinic, White et al. Basically, what they did was they got 2 groups, a control group where there was not going to be this intervention, and an intervention group. And they randomized the 2 and said, let's apply this tool. They had designed an asthma guidance and prediction system, which looks at quality of care, risk factors, and also outlines the outcomes for that history. But it does require a lot of time from the physicians to be able to import and go through the histories and contact families, etc., etc. Instead, this tool was developed, which allows the intervention to be undertaken through the machine. And the intervention basically then interacted with the guided system and was able to give recommendations. When the 2 were the intervention arm and the control arm were compared, there didn't seem to be very much difference in terms of acute exacerbation episodes. But there was a significant difference in the time spent by physicians. Less time was spent by physicians and physician associates in dealing in the intervention arm compared to the control arm. And the study workers suggest that they want to now increase this this study in a larger cohort. There's also lots of other exciting things ongoing, and we are talking about artificial intelligence. But there is a lot of smart wearables now available, which I'm sure you've all been, utilizing, and this is something that potentially we can also offer to our patients, and then merge that with the kind of technologies we've just discussed. I couldn't but help bring in my my experience of using artificial intelligence in my PhD thesis. And my PhD is in its last phases. This is one of the papers we generated, where we applied artificial intelligence to look at messenger RNA signals from patients with meningococcal sepsis. Now, one of the problems with patients with sepsis is the lack of the paucity of data, and usually AI systems require high levels of data. But we were able to show that it's possible by using some funky mathematics to be able to balance data sets, even if they were small, and to provide a high level of predictive accuracy. If you look at this table, anything going up to 1 is highly predictive. And surprise, surprise, if you look at the row saying ANN, it is artificial neural network. It's the deep learning network, the multi-layer network. Again, is showing great opportunity. Now, as clinicians, if we could predict our patients who are likely to be going into sepsis early, then we can modify the approach in something that's deemed a personalized medical approach, and hopefully hoping to save lives at early changes. At NMC, we're also engaging with teams to look at the opportunity of engaging with patients and their families before they come to the physicians, so that the AI tool can actually work with the families and ask questions, assimilate the responses, so that when the patients arrive at the doctor's surgery, there's a whole history that's already been undertaken. So that this is something we're looking to pilot. It seems that the Emirates Health Services have already undertaken a use of artificial intelligence to improve clinical documentation, and yes, it is the bane of our lives at the moment, with all that the IT capability to be able to continue to enter information and see the patient at the same time. So if we can do something amazing to cut down on that time, it would be really advantageous. We're also looking to work with a enhanced speech recognition system, with 3M. 3M are already applying this in multiple CR hospitals, where the interaction of the speech modality can be utilized by the physicians. So basically, as you talk, the computer writes. I've also, in my recent practice in the last few months, been using artificial intelligence in the form of Google Translate, and found it very, very useful. Not many people know this, but well before ChatGPT, Google Translate was out there as an AI module. But hitting its first few million of users took a number of years. ChatGPT, within a few months of coming into operation, hit 1 billion users within a few months. You can just see the pace of how things have moved on. There are limitations of AI, though. There's a data requirements, so you need to adjust the data sets according to what you're trying to model. There's bias and generalizability issues. So you need to be able to understand some of the nuances of the problems, so that you can generalize across populations. However, data sets from one set of populations may not be transferable to another set. That's something also that needs to be considered. A big problem of artificial intelligence is something called the black box nature of AI. Black box, as you just saw, you have the input layer, then we have this hidden layer, then we have the output. You give information to the AI engine, it comes through onto the other side, and then it asks you, well, it suggests a prediction or a pattern, and it just asks you to take blind faith and say, this is how it is, work something out accordingly. Now, if it's something trivial, or you can cross-check, let's say it's an X-ray, you can cross-check against that, you might want to give it a go. However, when it comes to more intricate medications and more intricate therapeutics, it can be a problem. So one aspect of medical AI application is now moving from black box nature to white box, and basically trying to make that hidden layer explainable. So a lot of you may have heard, and you will hear the term explainable AI, so that you can actually understand how the computer arrives at a decision. But it's very complicated and it's very difficult. There are also other models in which the physician can also put his input into the algorithm, and a expert user can have an impact on the model output. There are major ethical and regulatory concerns about it, especially now you've seen the pace of artificial intelligence and how much control do we give these engines. there's the issue of privacy. If you do analysis of your AI work using ChatGPT, how that is then taken into the engine, and you lose that privacy aspect of it as well. So we need to be looking at that. When we're talking to our AI providers, we're being quite strict, as is the Department of Health and DHA, about where the information is residing. Thank you very much.
Thank you very much, Dr. Asaf, for excellent presentation and finishing in time. Thank you very much. Now I would like to request Dr. Anurag Vajpayee, Senior Consultant Pediatric Endocrinologist at Regency Center for Diabetic Research and Training from Kanpur, India, very well known to all. Welcome, Dr. Anurag. Please start your time. I would like to request all viewers to write the questions and Q&A box. In panel discussion, our moderators will take up the question and discuss. Please. Could you please make full screen, please?
Are you able to listen to me, Dr. Saurabh?
Yes, full screen, please. Slideshow.
So they have very often I
Yes, it's okay. Yeah, no, again went back. F5 or down below one cup type thing is there down below. It is not in the slideshow.
Me for this presentation, and
the presentation is on, only make it full screen. Yes, now.
Can you get me now? There was some
yes. No, we are not seeing your slide. We are seeing your picture.
Yes. I'm just going to share it again. Yeah, there was some network issue. So hopefully you're able to see the slides now.
Yes.
Okay. So at the very offset, I'd like to thank Dr. Saurabh and the entire team of DPC for inviting me for this wonderful session. And I'm really pleased that I was able to listen to Dr. Asra in such a wonderful way. And he's really summarized the role of AI across different aspects of pediatrics and has made my life very easy in terms of the conceptual outcome. So I'll start off with this case, whom I saw a few years ago when I just come back to India, in terms of the evaluation and management and how technology really put some role in terms of perspectives and how I started thinking of using technology in various forms. So we had this 17-year-old boy with short stature who had presented a bit late in terms of growth. So by the time he presented, his bones were already fused. And he had very clear-cut features of celiac disease on clinical examination. And we would have thought that by giving gluten-free diet, he would have much improvement in other parameters, at least, although growth was too late for this child. Now, unfortunately, this child, because of the lack of awareness on the part of the parents who had been presenting late and at the part of the treating physicians as well, was not diagnosed as celiac, and because of anemia was given multiple blood transfusions. So at that point of time, I thought that we need to do something in terms of spreading the message, in terms of implementing clinical protocols. And the way forward, of course, was technology. And I'll talk about different aspects of technology which are there, which can really solve a lot of our problems in that perspective. And what's the role in terms of especially the artificial intelligence and other technological tools which can help out achieve in that perspective. So when, as a clinician, we are making a clinical diagnosis, we are looking at the clinical and laboratory clue, and then we try to summarize both of them based upon the current evidence and probably try to make an algorithm in our mind to make a decision. So we make our own decision tree to reach a particular management or recommendation in terms of clinical aspects. But the problem is that every year we have got so much medical publications coming in. So if you look at it, every year around 1.5 million new research papers are being published, and it's going to be very, very difficult to really follow them. There are like 60,000 RCTs which are currently registered with the control trial. So this is something which is going to be very difficult to follow, and getting the right evidence becomes difficult. So what happens over time is that we are trained in our own mind that we continue to do the same things, whether they are right or wrong, and that may be something which may take us away from the evidence-based practice. And therein comes possibly the role of technology. So while deciding the management of a particular patient, what are the particular options available? So one, of course, we can go by our own clinical experience, which of course will be very, very individualized because we will follow what we have been seeing, and there would be a lot of biases which may come up in that perspective. There would, of course, be lack of, because whatever we do, we have limited amount of time and we can use some of the data, but it will not be something which is going to be extensive or exhaustive in that perspective. The other option is, of course, is to use a sort of a decision tree. So a lot of these algorithms, a lot of these guidelines which come from the various societies do have this sort of a decision tree which can automate, and we can implement it using that automated decision tree. This would be something which will be good to use. At least we are following the guidelines, but they are very rigid. They are not particularly specific for an individual. They are more like overall one size fits all approach is what is there for these automated decision trees. It is based upon limited data, so it can be used a bit rapidly, and it follows an algorithmic approach, which may not be as good as clearly a model of artificial intelligence. And when I discuss about the various AI paper, then we'll see that often the decision tree-based models are the ones which have the first outcome in that perspective. And then, of course, is artificial intelligence, which is going to be more generalized, which will use big data, and it will help out reach a collective decision. So depending upon the clinical situation, we can either use one of those three, and I'll see how different aspects will have different algorithm in that regards. So automated decision tree is basically you already made a yes-no framework. So based upon the various scenarios, the algorithm is already fixed, and you go through those algorithms. We have been working a lot with many of these automated decision trees. And what we have seen is that we have been able to develop tools which are going to help us classify diabetes, identify the different types of pubertal disorders, interpret thyroid functions, as well as classify disorder of sexual differentiation, some of the more complicated scenarios in terms of pediatric endocrinology, using simplified tools, using minimal inputs, and they are doing at par with any pediatric endocrinologist, and they're going to help out in terms of a general practitioners. So these automated tools, they do not require extensive data. They are based upon simple inputs, can also be of help. Now, the problem or the challenge of developing an AI-based solution in these, which we're trying to work out, is the lack of data, which Dr. Asra Ali talked about, that we need large amount of data to really build up a model. So till that time, we have that much data, and we have got tools which can analyze and put them. We also have this automated tree, which can also be used as an option in that perspective. We already had a big discussion about Turing and his work in terms of artificial intelligence, and how do we decide about the Turing test to say what is a machine. And that's the talk of AI has been now somewhere around 90 years old. So a lot of work has been done in that regards. And we had this landmark scenario in which artificial intelligence was really coined in that perspective. So when we really compare a decision tree based approach, which is basically a yes-no based approach, which classify based upon the given scenario, to a natural language processing or artificial intelligence based approach, there's a big difference. Now, this decision tree will only be going based upon a binary sort of a model at each decision tree, while natural language will really look at a multiple aspects to reach to a particular diagnosis or particular outcome in that perspective. So it will be more complicated or a more scenario based in that perspective. Now, what really is artificial intelligence? And we had already some discussion on that. So there are multiple layers, so to speak, in that regard. So we have got within this a component of machine learning, which is a relatively simpler tool in which we provide the inputs, of which then features are being extracted and classified, and then the classification, as Dr. Asra talked about, whether it's a car, not car, or animal, but that sort of a model is done. So this is a more simplified scenario in which you don't need a huge amount of data, and it would be relatively quicker to develop in that regard. So many of us are using this sort of technique. So Netflix, the suggestion it makes based upon the movie that you want to watch, or many of these voice command systems like Siri or Alexa, they are all examples of a machine learning algorithm. Now, beyond machine learning, we've got deep learning, which is something which requires a more human-like scenario, as we were discussing about the convoluted neural network. So there are interconnections between these algorithms, and this becomes more complicated. So this is something which is complex, requires larger data, and it's of course difficult and more resource intensive to produce in that perspective. So this is something which is used for a sort of a difficult scenarios like image recognition, and talking about the face recognition and the syndrome detection software. So they will be using these deep learning techniques. And finally, we've got generative AI, which is going to try to mimic as to what we do in terms of our training. So if you look at what we do in our medical school, we will be going and reading a lot of books. We'll be seeing a lot of cases. We will have a lot of examinations which are going out. And then based upon the accumulated data, once we are faced with a scenario, we'll give a particular outcome or response in terms of the patient scenario, in terms of prognosis, in terms of evaluation, assessment, and management. So generative AI, based upon whatever information is there, is going to generate a response to a particular scenario. The classical example, of course, for that would be something like ChatGPT. So there are multiple levels, and these multiple levels are going to be explored in terms of medicine from that perspective. Now, just to put some perspective as to how the AI is embedded or implemented in a particular scenario to make clinical decisions. So this will be a typical scenario. You would need a big data. You need a large volume of data, which has got variety of informations, which has variability. It's not representative of one particular region or one particular population. It needs to be a large scale data. And data is the most important aspect, because we know that if we are putting garbage in, we'll get garbage out. So we need to have a data which is reliable, valid, varied, and extensive. And this data will then be put into the particular system. There are mechanisms by which we can tweak or pre-process the data a bit. And then we'll, of course, as we discussed, there will be a validation arm and the development arm. And from there, this data will come up and will give you the responses in that perspective. Now, there are various ways in which these artificial intelligence models will use, and they will give different ratings based upon that. And then we can choose which of these models are doing better. As Dr. Asrar wonderfully said, in AI, we don't know how the machine is going from point A to point B. So whatever thought processes are going on is not very clear. Although now we have got some explainable AI systems wherein you would be knowing about what sort of scenario. So post hoc analysis can tell you what was the basis of that particular decision, and then we can decide whether it's clinically relevant or not. So the data that's been given is extremely important, and therefore it has to be generalizable to the population where you want to implement that in that perspective. Just to give an example of how a particular aspect of the particular analysis is looked at, if you're looking at particularly a histology, which is something as radiology, a very common scenario in which the various aspects of AI being implemented, the machine or the intelligence system will be looking at what is the particular aspect to look at. It will give specific weightages to that and then make a decision in terms of how to classify from that perspective. What about generative AI? So as I said, as we are being trained as doctors, we learn a lot in our medical school. We see a lot of patients, a lot of images. Similarly, the generative AI is being fed all the possible text, audio, images, records. All the data is already there, clinical notes, so large volume, large corpus of data is there. And then there are interactions which happen in that particular, and then the generative AI can do the magic of putting in a lot of factors like developing note-taking, augmented procedures, radiology, picture-based, image-based decisions. So this is something, the way for the future to really get at close to how our medical system is working from that perspective. So I'll go through a few sort of case scenarios. Already, Dr. Asrar has talked about wonderfully about the role in terms of sepsis, in terms of asthma, and in terms of radiology. So I'll touch base some different aspects of how the AI systems will help us predict, triage, diagnose, and treat particular conditions. So this is one scenario of a 2-year-old boy with bronchial asthma on inhaled steroids with fever and respiratory difficulty, has a saturation of 94%, mild tachypnea. There is a bed crisis, and you can't admit everybody in that regard. So how do you decide? you can go ahead with your own clinical decision. Okay, these are children will improve, so I can send them home. You can have some decision tree in which you will say, okay, saturation above 92 or a respiratory rate below 40, don't need admissions. This sort of thing will be there. But what can AI do? So this I'll show you as a model. This is one of the study which really predicted the need for hospitalization and asthma. Now, if you see, this is a large amount of data that is required. So they're talking about 449,000 individuals. And out of these, a lot of visits had to be removed because the data is not available. But still, they had 30,000 visits of children with asthma who presented to the emergency room. And based upon that, they do some complicated modeling. We don't really know about that, but we know that it has got a good predictive accuracy in terms of the need for admission. And they have different sort of models there. And I'll show you how decision tree based model, which will be that algorithmic model, has the lowest area under the curve. So it's got the worst predictive value for admission. So this is a way, if you can run the tool, it's very easy to triage which child requires admission and which child would need to be admitted very quickly from that perspective. So this is one part as far as prediction is concerned. Now, the other aspect is another child, 10-month-old boy with febrile illness, has fever for 4 days, has on investigation some leukocytosis and a decrease in platelet counts, admitted in the ICU. What about the prognosis? And this is something which is often important in terms of the various complications in that regard. So we can go by our own experience, as I said, or go into a decision tree, but AI is also there in that perspective. So this is one of the studies published in Pediatrics around 4 years ago, which tried to look at the prediction of serious infections in young febrile infants. And this was based upon a database of around 4,000 individuals to begin with, and then they classified into 700 as derivation group and 700 as testing group. And then the AI was able to identify specific markers of a serious bacterial infection in that regards with a reasonable level of accuracy. So there are ways in which we can test scenarios which will be difficult to predict and use AI to decide about in that regards. Now, machine learning has now also been used in terms of many of these prediction models. So particularly one major concern of the pediatricians and the parents, particularly in that regards, is how would the premature infants after discharge do in terms of their long-term neurological outcome. And this is a large number of database in terms of trials, which has shown that AI-based models can predict neurodevelopmental outcome. And this could be very helpful in deciding the need for early intervention in these individuals. And we'll have already a target group which will be at a high risk of developing complications in that regard. So this is something which we're looking at in terms of predicting not only the short term, but also the long-term prognosis in that perspective. I'll go to one of the scenarios which is very close to my heart, a 4-year-old girl with DKA who was treated with fluid and insulin outside and hypokalemia, was given normal saline followed by infusion and unfortunately developed arrhythmia. Now, this is largely because of, despite the availability of standardized protocols which are there, they are not really implemented in the letter and spirit. And these confusions, particularly in the first hour, which is the golden hour in the treatment of any acute emergencies, can have implications which cannot be altered in that regards. And this is something which has got huge implications. So what could we do? We can, of course, train the personnel, but it's going to be very, very difficult to do that. The other option would be to develop an AI-based tool, but then you would need thousands and thousands of DKA admissions, put in all the data, and then based upon that, AI can help out. So herein, what I'm going to say is that the automated decision-based tree approach is also something that is quite helpful in that regards. So if this is what our experience was, so when we really evaluated in terms of our ICU admissions with DKA, we found that despite written protocols and despite repeated training of the staff, there were many errors, some minor, some major in terms of the management, and that resulted in significant component of hypoglycemia, hypokalemia, and dehydration. This was something which was preventable if we had followed the protocol properly. So what we did was that we developed a sort of a decision tree-based approach, which took into considerations multiple parameters like the level of dehydration, the level of pH, the carbon dioxide level, the blood sugar level to guide the initial management as well as the subsequent management of DKA. And when we really used it, we found that this had a significant impact in improving the compliance as well as reducing the complications in that regard. So these automated tools, till the time a large collaborative data is available and AI may be beneficial, they still will have substantial improvement in terms of clinical outcome from that regards. As I said, treatment decision is an important part of pediatric practice, and there are, this was alluded also by Dr. Asrar, that there are ways in which automated treatment plan is being developed for various forms of malignancies in terms of the dose of radiation, that this is very complicated based upon basic data. So this is something which is extremely important. One very important point to remember is that while we as clinicians look for specific data to detect either the diagnosis or prognosis, so like in the case of DKA, you say, okay, we look at pH, we look at CO2, we look at bicarbonate, base excess, and those parameters. We don't know from an AI perspective as to what will become important in terms of clinical relevance. So whatever the large amount of data is there with you, maybe the heart rate, maybe the urine output, maybe the temperature. So you have to put all the data in, and then AI would do much better if it's got much more information in that regards, in that perspective. So having discussed about the triage role, about the treatment perspective in terms of predictiveness, we have another issue in terms of diagnosis. So we have a 12-year-old girl with short stature who clinically, if you look at the growth chart, looks like a nutritional pattern short stature, which we have done a lot of workshops with people and people know, understand that. But unfortunately, it was labeled as growth hormone deficiency based upon some of the biochemical variations. So this is not an uncommon practice in terms of some of those scenarios in which a lot of algorithmic knowledge is required. It causes confusion, resulting in unnecessary treatment in that regard. So what could we do out here? We, of course, can train the clinicians and clinicians can practice that, but that's a long-term tedious process. We can develop AI, but again, you would need thousands of children with short stature, all the data, all biochemical workup, and you will classify them into different diagnoses. So one approach which we followed again was decision tree based approach in that regard. So we have these algorithms which have been developed, and these algorithms, when we were able to study, found that they, based upon the very, very few parameters, only 5 parameters, we were able to get around 98% accuracy in terms of clinical diagnosis and concordance, which was significantly higher compared to both training pediatricians as well as practicing pediatricians. So there are ways in which we can implement the knowledge in that regards. Another scenario related to pediatric endocrinology, a 13-year-old boy with short stature, and we can see the child is short. Now, the bone age was read by the radiologist and was reported as 14 years. Now, in this scenario, when you're looking at bone age of 14 years and a child who is very short, you are concerned, and the doctor had prescribed growth hormone treatment. But when we reassessed this bone age, we found that this was actually 10.5 years, and there was no need for treatment, and this was looking classically like a constitutional delay of puberty and growth from that perspective, and only follow-up was required. So an error in making the diagnosis, and this is something which is not uncommon, and often in areas where the quality healthcare is not really accessible, it may become difficult in terms of interpretation, not only bone age, but number of other radiological parameters. We were discussing about the chest X-ray based diagnosis. Dr. Asra talked about the pediatric brain tumor classification. So this is something where there could be a potential role of various forms in that perspective. So we know that there are various techniques by which we can assess bone age, including the GP Atlas, the Tanner Whitehouse, but these are complicated methods which require a lot of training and require a lot of time, which are not available with pediatricians. We have developed a simplified image matching way in which we are able to get appropriate bone age within 4 to 6 months for expert and 6 to 8 months for non-expert users in a 2-minute time frame, using this just matching of these images. And being encouraged by that, we are working on an AI-based model which will give you instantaneous results in that regards. And once we incorporate this bone age into those basic parameters of puberty, growth, and bone age, we can then do a lot of predictions in terms of the likely diagnosis and likely management. So these integrated systems within the EMR can go a long way in improvising outcome from that perspective, and they are expected to improve the concordance score. And this is one of our studies compared to the pediatrician, the pediatric trainee, by a substantial manner in that regards. AI-based methods are already available, although the mean absolute error for most of these AI methods at the moment is higher compared to the humans, around 6 to 9 months. Once they come around 4 to 6 months, I think this is going to be something which make it very easy in terms you put the X-ray, you get the right bone age in that perspective. One area where there would be a significant role also in terms of diagnostics in pediatrics is, of course, the various syndromic presentations. And we know that they can be really difficult and you need a lot of training to really fathom many of them, and still the diagnosis remains unclear. So these are the studies, and this is a big, the phase-2 gene, a very, very commonly used AI-based tool, which basically matches the image to the closest syndrome, and you're able to read that. They have got a number of publications in identifying various forms of syndrome. So this is something which is going to assist the clinician also from that perspective. And as Dr. Asra was talking about, radiology is about large amount of data. And as we are talking about the whole genome rather than gene analysis, whole proteome rather than protein analysis, there's talk about radiomic analysis, in which the radiologist can also only see a few areas, a few pointers in that particular image. The AI can really look at the entire data, and that can be used using a CNN or the convolutional neural network to identify a particular aspect. So this radiomic approach is something which is going to help out in multiple aspects. And this is what may help in terms of classify various sort of brain tumor etiology. Now, another scenario, so we have been talking about in terms of the physician intervention, in terms of making the diagnosis, making the treatment, making the image-based diagnosis. What about conditions where they need regular monitoring, management in terms of clinical scenarios? So type 1 diabetes is clearly one of the most dangerous, most difficult disease to have. You would need to monitor your blood sugars frequently, every 4 to 6 times a day. You would need to prick, you need to give multiple injections. If you miss a dose, you will develop DKA. So what do we do in this scenario? We can think of developing AI-based interventions which will guide in terms of sick day management as well as insulin dose. Or we can think of simpler decision tree model, because AI would need a large amount of data again from real life scenario in that perspective. So we are in the process of developing our application, which is going to use multiple parameters to decide about the appropriate insulin dose, which is to be given from that perspective, and then go forward from that regards to guide the individual about the daily need of insulin, the need of insulin in specific circumstances, and the sick day management. There are already some preliminary data, and I'm saying preliminary because there are a lot of variations there which are using multiple informations or variables in terms of the availability of carbohydrate content, in terms of the insulin existing dose, to guide about personalized insulin dose. So this is something that's going to go a long way in terms of type 1 management. Of course, the artificial pancreas concept of advanced hybrid closed loop does use a lot of AI, but many of our patients still are on basal bolus regimens where these calculations become absolutely important from that regards. Now we are also now talking about scenarios in which some complicated patient comes to us and we don't have the specialist opinion available immediately. And this may be particularly common if you have somebody who's working in a remote area. So we have this case of a 16-year-old girl with weakness and lethargy, vomiting, pigmentation, hypotension, hyponatremia, and hyperkalemia. So looks like there's some issue in terms of adrenocortical insufficiency. And of course, if you have a backup with pediatric endocrinologist, you can make the diagnosis very easily. But what do you do in these scenarios where you are not very clear in terms of clinical management? This is just an illustrative case. You can go through big resources like textbooks, but once you go to the textbook, you'll start with physiology, pathology, and then by the time you reach the particular management, it's already too late from that perspective. There are wonderful e-resources available, but again, their structure is difficult to fathom from a case perspective. There are learning portals like ours, which is available, which we can provide. But what about large language models? I'm sure everybody has used ChatGPT and how it can really help out in that regards. So what can large language model do in terms of clinical management? So now we have got this Glass AI, which is a wonderful tool from a clinical perspective. Now, what I did was that I just put this case and saw what it suggested. And if you go onto that in that perspective, what you're seeing that within a few seconds, it will analyze the whole data and then will start off with a comprehensive review, give particularly personalized recommendations in terms of the clinical profile, in terms of the differential diagnosis, in terms of what should be done and evaluation. So this is something, a novel way of not only learning, but in terms of practicing, in that whatever information has been put into it, in the form of records, in the form of publication, in the form of that, it will come out in that. So this is again, in complicated cases where you don't have AI model for everything, you can at least have information which is available immediately, which is specific for a given condition from that perspective. So we've clearly shown that AI in healthcare is helping us diagnose cases, triaging patients who need immediate help, providing recommendations in terms of treatment, and prognosticating also in terms of scenarios as we discussed about the febrile illness or the bronchial asthma prediction. And this is what Dr. Saurabh talked about. A large number of publications are coming from AI across board, including pediatrics as a specialty. So are we really looking at AI being the key as far as the future of healthcare? And this is from the Topol review for NHS, which really shows us how dramatically they expect the AI to change from telemedicine to smartphones and wearables, which are already there in that perspective, to going into interventional robotics, which is going to be really, really something which is going to be a very difficult scenario to even fathom right now. Predictive analysis and writing the genome also. So they anticipate that over the next 20 years or so, we may have path-breaking discoveries in that regards. And this is something which we have to be very, very clear in that perspective. Now, whenever a new thing comes in, we are always worried whether this is going to have a positive or a negative outcome. And this is something which is, we need to be aware about the limitations as well. Now, as I said, the entire way AI is trained is data-driven. So if the data is not representative, the data is biased, the data is limited, the output and responses will also not be good. So an AI system which is based upon a particular group of patients, be it ethnic, socio-economic, or regional, will not be generalizable across the globe. So this is something which is important to understand. Of course, AI would not have the human interaction, which is key as far as medical management is concerned. Many places the logic is unclear. So we are not sure what they're using, although explainable AI may help out see whether it's really a biological plausible or what sort of modeling has been done. And this clearly becomes a case as far as tight regulation in that regards. So is AI a big threat? If you do any search of AI and employment, there are a lot of talks about how AI could have an impact in that regards and whether AI can replace us doctors as well in that regards. Now, just to give you some basic statistical inputs, 77% of corporations are using AI in some form or the other. So it's probably affecting the overall job flow. A very interesting statement which I read was that 70% Chinese people were willing to replace politicians with an AI-based model. So this is the sort of acceptability that population is happening. So I don't know how many are willing to change their doctors with AI, which will be an interesting question to look at. And based upon some estimates, over 300 million jobs are going to be affected by AI. So AI is there, and we need to be ready in that perspective. For my takeaway would be that we need to really collaborate with AI and don't just think that it's a threat, it is a positive thing. But we always need to be cautious also in that regards. And this test case example of Babylon Health, which was widely used in NHS in terms of triaging patients based upon the automated bot system. So this was basically a sort of a AI-based chatbot system in which the patient will come in, they will give their complaint, and it will continue the conversation, and then it will finally guide whether you need a particular input or you don't. It will reassure them. And this sort of system was taken up hugely by NHS and across many countries in the world. And at one point of time, Babylon was really said to be a wonderful product. And 1/3 of adult Rwandan population was under the Babylon. So they were just getting the information about their healthcare from this particular system. But within 4 billion evaluation, 2 years of that, this system really failed, and it was found to be extremely having a lot of confusion in terms of the guidance, the diagnosis. And of course, this is something which we need to be wary about, that we should not overclaim whatever is present at the moment, and this needs to be taken with a pinch of salt. And whenever you saw those articles I was talking about, the sort of accuracies are still not to that level in which we can really go ahead in terms of automation. So just to give you a perspective, and this is just like a current perspective, so to speak. So our brain has the capacity to do around 1 million trillion operations per second. And if we compare that to our AI, which is very advanced, doing 93,000 trillion, that's 100 times slower than our brain. The size of our brain will only be 1.4 kg. The size of this machine would be humongous at 150 tons. We would need around 20 watt of energy, while this machine will need 10 million watts. So while there are a lot of work which is going on in terms of AI, and we do expect a lot of interventions there, we need to be very cautious also that the human needs to be in the loop when we're talking about the AI. So we talk about AI, it's not just a conflict, it's basically a partnership in which human has to be there in the loop to make a final decision in terms of the intervention. There would be in the form of assistance and a tight regulation, which has to be there from that perspective. At the end, I'd like to acknowledge my entire team, my teachers, Professor Menon, Dr. George Werther, tech team, Shalabh ji and Prabhat ji, and the whole entire fellows who have been working a lot, and our collaboration with IIT Kanpur in doing a lot of these work, especially the AI-based work. And again, thank you, Dr. Saurabh and the entire team DPC for inviting me for this interesting session. Thank you.
Thank you very much, Dr. Anwar, for this excellent, illustrative, informative, innovative. I don't have words to express. Really, everybody enjoyed. Now, I would like to request Dr. Anwar, Dr. Asrar to join the panel. I would like to request our engineer Rachil Sengupta from San Diego, United States, to join us. Dr. Kalpana, Dr. Diari, to start the panel, please.
Thank you,
Rachid has
Dr.
not
Saurabh.
joined us.
Thank you, Dr. Saurabh. And
I'm
both
here.
speakers, Dr. Asrar
He
and
has
Dr.
joined.
Thank you very much. Thank you. Yeah, Dr. Kalpana.
Yeah, thank you, Dr. Asrar and Dr. Anurag. Fantastic talks. I think when we were deciding on this webinar, we were feeling a sort of, we were out of depth, our own depth. We didn't know much about AI. You all have brought us up to date from clinical point of view and, clarified things beautifully. Having said that, AI is still in its early stages, in its, I would say, partnership with doctors as such. Its impact will be known maybe in the coming years or so. So it leaves us with a lot of questions in our mind. First of all, Dr. Asrar, you have done your PhD and looked at specifically AI in pediatric healthcare. So I just wanted to know from you, what are the areas you think that really it is already being used before I go to anything else?
Dr. Kalpana, thank you very much. An excellent question. I was in Washington Children's Hospital, National Children's Hospital, about a year ago, and they took me to the cardiac suite, pediatric cardiac suite. Now, if you recall, post-COVID, we've had a major nursing issue, and what they were able to do was utilize multi-camera system, where a senior nurse was in the cardiac suite and would be managing all the nurses, and the physiology and the cardiovascular aspects were also being inputted into the system. And there was an AI module that would then also flag up patients early on, so as a preemptive measure. So that's already an example of technology that's already used. And as I say, I think we're all in a learning stage. But the great interesting thing about all this data is that hopefully the systems should all improve as more and more data goes into these systems. I hope that helps to answer that question.
Yeah, sure. So as far as data is concerned, it brings up a lot of questions. First of all, from engineering point of view, Rachit, can you tell us how is it different? Like, how is machine learning any different from your traditional software engineering from an engineer's point of view?
Yeah, sure. So I think both Dr. Asrar and Dr. Anurag did a good job with their with the images they showed of how these machine learning algorithms work, right? And so the takeaway for anyone should be that in traditional software engineering, what we would do is define those rules beforehand, where we would write code, we would write an algorithm that if this input comes in, then we should go down these paths and we should have this specific output. With machine learning, we've changed the dynamic. Now it is that we take this data, give it to a machine, and the machine is itself coming up with the rules. It's itself coming up with what it should do when it sees different data. And then when you put it out in production, it's all about getting more data, and the machine, which has already learned these rules on its own, it's not had a engineer come in and tell it that these are the exact rules you need to follow. So that's kind of the difference going from the old traditional software engineering to more machine learning systems.
Rachid, what's the difference between machine learning and deep learning, and how the artificial intelligence get use of these two?
Yeah, so machine learning is, I think Dr. Anurag had that image, right, where you have the artificial intelligence in the big box, you've got machine learning, and then you've got deep learning, right? And so you can think of deep learning as a subset of machine learning. Machine learning, we have different types of algorithms that we can use, which are not deep learning. So those could be things like decision trees that Dr. Anurag was talking about. And so what differentiates that from deep learning is really the neural network, right? So a neural network is basically, it's inspired from the human brain, where engineers are trying to recreate the human brain, and you've got these neurons that get activated. And so engineers took that model and created this neural network. And then what makes it really deep is the different layers. So I think Dr. Asrar had that diagram where you had the input layer, the output layer, and then the middle you had what was called the hidden layer. And really what makes it deep is the more hidden layers that you add is what's really making it deep. And then obviously the next question becomes, okay, why are we adding these layers, right? Why are we adding these hidden layers? Like a very conceptual model to think about it is each layer is helping us make some new decision on the data. So let's assume you had, I think Dr. Anurag had that car example, right? So let's say you have a red, let me change it to a bus. So you have a red bus coming in. Each layer in that network might be making a different decision. The first layer might detect that this is a red object. The next might detect that there are wheels there, so it's more likely a transportation vehicle. And then the third might detect that, okay, now that I know it's a transportation vehicle, it's most likely a bus based on the size and diameter. So that's kind of what makes neural networks into deep neural networks and deep learning. You're just adding these layers so that the machine is able to come up with more and more decisions.
Thank you. Thank you.
So the examples that Dr. Anurag showed, already he's been using a lot of those automated systems which have made the life of pediatricians easy to diagnose pediatric endocrinological disorders. That is done through a traditional software engineering. It's not a part of AI.
Yes.
That's what we take away from that, or we consider it.
No. So they are like automated decision trees. So they are basically not really intelligent. In the sense, intelligence would mean that it will be doing itself. So we are really training them that if this happens, you take this and this and this. So this is the way you make the decision. Now, in many scenarios, that may not be. So we need to just understand that it's not just AI is going to be the best thing or solution for everything. In many scenarios where you are able to achieve very good outcomes, using those automated trees, it may be very, very much good enough in that perspective, because our collaborators in IIT in many cases said, why do you need to create an AI when you're getting such reasonable results? And if you want to implement a particular, let's say, guideline in terms of management, you only need those parameters. So while AI is something which is going to help out in very complicated and real life scenario, that's not that it's essential for each and every aspect. And you need huge amount of data. That's what my limitations is also there in that regard.
So at the end of the day, whether we are using these automated systems or we decide that a particular clinical problem or approach requires AI, the role of doctors still remains, isn't it? So the engineers would need that input from the medical professionals to tell them. So there's no threat there as yet, I suppose. The two branches that were, if we read the literature, the radiology and pathology, these are said to be, I think, maximum work is being done in radiology, if I'm right, Dr. Asrar?
Yes, indeed. I have to also say that imagine the general pediatrician in the clinic. Imagine general pediatrician has to refer to his specialist colleagues, but before the general pediatrician does that, maybe he sends the patient for the MRI or the CT scan or the ECG and all the information, like he's interpreting the biology, the chemical pathology results. He's also now beginning to interpret, according to the AI engine, aspects of the patient. So it may be further along the line. In fact, the general pediatrician has probably now become that multidisciplinary coordinator in that whole mix. And eventually, when the patient then reaches the specialist, maybe a lot more has been done for the patient, and it may be a more meaningful journey rather than the delays and all the issues that sometimes come in terms of cross referrals.
Right.
May I ask the panelists now, as we know, the AI needs a lot of data, so to be trained properly. So I'm asking, how do we train AI when we don't have a lot of data, for example, in rare conditions? The question is not clear or clear?
That was a very good question, Dr. Diary. And I think I will touch on it, but I'm sure Rashid has probably got more intricate information. But my professor is always talking about generating probabilistic data. So what happens is you get the machine then start generating random data, and then you start putting that into the system according to certain rules as well. So so that it's truly modeling a really, a random, everyday situation. I think Rashid, you might be able to provide a little bit more insights on that phenomena.
Yeah, so I can add a couple of things. So I apologize, I don't remember if I saw this in Dr. Asra's or Dr. Anurag's slide, but there was an example of one of the experiments where they ran, and the images, they basically did different types of data transformation where they rotated, they change the size, change the pixelation. So that's an example of where you are creating with a smaller amount of data, you're creating more data by just transforming it. So the machine is learning that, okay, if I see the data in some other way, it is actually the same thing, right? So that's one way you can use the less amount of data to generate more. The other is, as Dr. Asrar was saying, is synthetic data. And so that's a field that we are spending a lot of time trying to figure out. It's still, I would say, a relatively newer field. There are its own challenges where the synthetic data might be, at the end of the day, all of these models are dependent on the data that comes in, right? So even when you're generating synthetic data, the synthetic data is going to be similar to the data that came in. It's not going to generate new data. So let's assume that all of your synthetic data is from children with a, let's say, European heritage, so that genes have something that you might find in the European person more often. Even the synthetic data that you generate will be similar to that. And so that poses a challenge that now when you take this and apply it to children who are from, let's say, a South Asian background, do those same genetic markers translate over, or is there difference? And so it's still a relatively new field. At the end of the day, data is still the most important thing in all of this. If you don't have good data, you cannot build good machine learning algorithms. As it's based on data, it's basically garbage in, garbage out, right? So if you put garbage data in, you're going to get garbage predictions out. And so we really need to make sure that the data we are putting in, we understand what it is, and it's high quality data.
Right. I think there's a question.
I just like to add on that. Probably we need to understand that since data is the primary thing, and since while images, we can make some modifications in terms of clinical data, I would have some reservations whether we can use synthetic, because every child will have a unique perspective and will give us better opportunity to really develop that data. So by using a synthetic data, whether in a large model, whether we are really just increasing the number of data, this is something which needs to be picked up. So these are things which will come up, I think. The biggest challenge I would say in pediatric has been the data. You need to have representative data from a large number of population groups, large diverse groups, and often missing data. What do you do in many patients where the data is missing? So many studies I was quoting, they'll start off with like 499,000 individuals, and then they came down to a very small number of data. So these are the things which are very, very difficult. So in future, if we develop the EMR models, which are taking all the data, extracting in an ethical manner with privacy, and there's so many other issues there, I think this is something which is the biggest challenge at the moment in terms of medicine and AI.
Yes, Dr.
May I
Anurag.
drop and ask one question, Dr. Kalpana, if you allow
Yes,
me?
yes.
I would like
Sure.
to ask panelists, giving, the best information to the system, what are the areas where the AI can commit a mistake and give us the wrong information? What are those areas in medicine or pediatrics where there are chances of getting wrong information? Any of the panelists?
I guess
Maybe I can take a first
Suppose,
shot.
as you said, artificial, the atypical pneumonia, the machine can miss. So what are the examples in this? We should be careful. We should not 100% depend on the machine.
Maybe I can give a general answer, and then maybe Dr. Asrar Anurag can talk more on the medicine part of it. So from a general standpoint, there is a quote from a legendary statistician called George Box, and it goes, all models are wrong, some are useful. And at the end of the day, what what all AI is, it's just a model. And so models always have room to make mistakes. And that's really going back to earlier points about human in the loop and always having doctors there. That is the key. You talk to any AI leader, anyone who's building AI machines, no one is trying to replace any job. It's all about how do we enhance the productivity, how do we make the job easier. And so at the end of the day, you always need that expertise of the doctor or any other job to analyze the output that the AI is putting out and make sense that, okay, does this output really make sense, or is there some factual issue with it, right? You have to remember, at the end of the day, the model only knows data, it does not know reality. So that's just a general idea about how to think about models and the predictions. I'm sure Dr. Asrar and Anurag will have more medicine-specific examples.
Yes, actually, if I could take that on, Rashid, I think the emphasis is on the word model, and we are trying to modelize everything. Dr. Shorab, I think that the philosophy, and the patient comes into our surgery, is the patient got this condition or that? For example, does the patient, my child, have asthma? How are you going to say yes, or are you going to say no? Or sometimes it's a gray area. And the problem dealing with this gray area, when you put a model which says yes or no, is that actually indicative of the true life situation? So these are some of the challenges which I can sort of say could kind of make it difficult, because I'm at the moment trying to analyze an asthma model, but the asthma model is dependent on our benchmark. Our benchmark are GINA guidelines. The GINA guidelines, though, talk about specific categories. But when a patient comes in with asthma, is it allergic asthma? Is it just a little bit of a cough related to a bit of atypical, infection or whatever? It's so complicated. So I think these are the areas that are potentially open to difficulty and challenge when we try to put a model to everything.
So just to maybe give an example from pediatric endocrinology, let's say there are models which are there in terms of insulin dosing, and they were looking into various factors, as of course, in terms of carbohydrate intake, in terms of the activity level, in terms of the sugar levels, and in terms of dosage. They will give you recommendations. But there has to be a way forward to look at that these recommendations are not going out of bounds, and we need to really judge them. So ultimately, there has to be some sort of a limit setting probably. So if I think of developing an AI in insulin, we'll set some limits that you can't go below or above this particular dose, or you inform the doctor in that perspective. So there has to be the patient in that case, because that's an even more complicated scenario where we're not talking about the doctor taking the decision, it's the child who's taking the decision. So this is something, so there are various areas I think we need to really get things sorted out before we really go ahead in terms of, and we have to be in loop. And that's why it's the excellent model of Asra was talking about, the monitoring in the ICU. So it will giving you a lot of information and how things are going on. But ultimately the intensivists and the healthcare professionals who are there are going to take action based upon that. So the human in the loop, I think, is the crux from the entire discussion from my side, I think.
Dr. Anurag, I absolutely agree. I think it is such a challenging area, trying to get this right. In fact, this may be one reason we don't have a prospective study of AI versus a machine versus a man. at the moment, because nobody trusts it to that level as well.
And most of these, I would say, the insulin dose studies are also based upon what the expert will recommend and what this machine recommends. So it's not really a real life scenario. So that's a very, very important time, because we are not even ready in a trial scenario. So what about a real life scenario? I think it's going to take a long time from that regard.
Exactly.
The only way potentially I could see things being utilized earlier is because, cost of healthcare, one of the major costs is personnel. Some of the peripheral hospitals in certain countries are developing their health systems. The cost is such a difficulty. So they may start to implement those sort of AI strategies at an early stage as a cost-saving measure, and eventually down the line, things may become more mainstream.
I'd like to just share an example of the dangers of not having human in the loop. All of us witnessed this in very public with the news of the disasters that had happened with Boeing. For anyone who's not aware, basically the Boeing planes crashed, and it was due to the machine making a decision. The decision was an illogical decision on the flight path. And because the human in the loop was not brought in, where the pilot's expertise was not pulled in, and the pilots did not have a chance to correct the system, it led to disasters. And so it is very important, at least where the state of the technology today, that we have experts there who can correct the system when something goes wrong.
Yeah, so I'm sure we are at a very early stage still. There's a lot to be developed, lot to be done. And probably we'll have a specialized branch developing even among medicine, to look at this. And each society, each subspecialty will have its own guidelines. That would be probably, in the future, a long way to go till then. I think Dr. Asrar had a question from one of the doctors. He said, you mentioned that for atypical pneumonia, AI is still missed. How is this being addressed? So would you like to?
I guess this is one of the things we talked about, the model, the type of data we're using, and the X-ray of an atypical pneumonia, of course, can be, it's not just the X-ray, but also sometimes the clinical scenario. Patient may not look, the symptomatology makes you then do the X-ray, and you see this, say, okay, well, this could be atypical. So I think we probably need to put other things, other information into, and not just make it just about the X-ray. And I think that will be the ideal scenario in this context. Whether we can get more information from the X-rays using the CNN type of things, to see whether a new sort of way of looking at X-rays is possible as well. Of course, we only have a two-dimensional sort of image, which is also difficult. Which is why I think, going back, taking into the context of a clinical history, I think, is important.
Absolutely.
Some questions regarding responsibilities, liabilities, and misdiagnosis. So how you address this issue?
I think at the moment we can't really, none of the AI systems will claim that they are responsible for medical management, and this is going to be, the ultimate decision has to be taken by the clinician. So the responsibility has to be at the clinician. They're not even claiming that at the moment, I would say. They're at early stages of intervention.
I think there was another question from Dr. Jansi talking about, we are stressing so much about the data, and are we going to take the consent, from the patients before using their data? I suppose the consent forms would be changing. Yeah, Rachel.
I can take just a first shot. I can't speak specifically about the medical industry, but just in general, I think a lot of these questions are coming to a topic called responsible AI. It's a very important topic all over the industry right now, on how do we, and it has multiple dimensions, right? So some of the dimensions of responsible AI is the data you're dealing with consented data. So we have cases where there are companies using data from other companies without approaching them, or using individual data without approaching them. And those are going to, at least in the US, all the way to the Supreme Court to get resolution. And so the responsible thing to do there is to make sure you're getting consent, and not only getting consent, but if you're going to use that data in any kind of model, you are removing any kind of personal identification information, so that you cannot exactly identify it was from this person. It should all be anonymized data. The other dimensions with responsible AI are your bias and fairness. So I can assure you that any AI system that you have been given will have some form of bias. And as practitioners and users of this AI system, it is important that you understand what the bias the system has, so that you can make the best judgment on the outcome of that the model gives out. And then at the other dimensions go into environmental sustainability and whatnot. I'm not going to talk too much about them, but what I will say is that the majority of people who might be listening will fall in the bucket of either using an AI system in the future, or being a domain expert who's helping an engineer build an AI system. And if you are in either of these buckets, you need to be well aware of the topic of responsible AI. And so that is some topic that I would definitely spend some time reading and understanding a little better.
Yes, Dr. Asra.
Yeah, I touched on First History, the company from Canada that's approached us to be able to take information from parents before the child comes into the hospital. One aspect of their module is the first aspect. The first screen is the consent, so that's important. But data, in some aspects, data can be very valuable. My research, for example, I've utilized data, genomic data from multiple different data sets, but each of the studies have had consent as implicit part of the research process. So I think consent is, I think that's a really good question. I think consent should be, a part of the whole process always.
Right.
Dr. Asrar, how can we involve patients and their families in the decision making when we are using AI?
Yeah, I guess. Yeah, that's a very important and very philosophical question. It depends on the case that we're dealing with now. Now, let's say there's the gastroenterologist. He's doing a scope. He's using the AI module to ensure he catches all the polyps. The AI artificial intelligence engine is saying, but he doesn't actually, as part of the consent, when he does and asks the family, I'm going to do the scope, I'm going to go in, I'm going to use an AI module. I guess it's really about AI being part of the technology. Used to be the case, for example, they used to think that the traffic light was artificial intelligence. In fact, it was just using a sort of an algorithm. And now, it's just become a part of everyday life. So yeah, I guess it depends on what level of detail you want to go to, and it depends on the implicit impact. If it's about chemotherapy, then you're saying, the AI doctor has decided this for you. That's a big ask at this moment in time.
Really, not all the people, they are educated and well, understanding what we are talking about. AI, we are artificial, we are treating your patient or your son according to this one, to this model. I don't know, honestly. When it is coming, I feel it is difficult to translate this in a simple words to them.
The good thing is Dr. Dari, I think everybody's using AI. They don't realize it, part of their life. There's all AI going on that people don't realize. And if we can just get some case models, say, that app that you use every day that uses AI, they're like, wow.
And I think the key would be that we would say that this is going to assist us in terms of reaching the diagnosis or management, but this is not the main guiding. We have to own up with that, and that we are making decisions based upon these. But ultimately, it is our responsibility, and we have to decision our own this thing. I think that
so there is another question from here. How do you validate the data that goes to the system? How you do validate these data? who will validate, the third party or who? Especially in medicine. This is not in a trading or on an economy, but
Yeah,
like-
There are a lot of companies who are into it. I suppose they'll have to have their teams who would be responsible to validate, isn't it?
The implicit aspect of data going into AI is that some of the data is not right, and the question is how much of the data you need to be actually right for the end, because it's trying to model real life situations as well. So there's the complexity aspect of it, which is why we moved away from the statistical approach to this AI approach.
There is also a push right now on making sure that the data that is going into these AI systems is reviewable by a third party, so that you can make sure that it is first consented
Validate.
data, that it's anonymized data, and it's good data in some form or fashion, but it's still we are still very new in this journey, and so we still have to build those both ethical and legal frameworks to deal with these kind of issues.
Dr. Jhansi is asking about the opinion of integration of AI in education. How is this integration going to change the outcome of future doctors in terms of achieving competency?
I think this is a big role. I think that's something which AI can really help us. In a lot of ways, it's already helping in terms of creating so many simulated scenarios in terms of the likely diagnosis, likely evaluation, management. Getting the information from vast textbooks is very difficult to get that. If you use AI, you can get the particular filtered aspect in that regards. And I think those models will really go a long way in education. So I think the one initial intervention would largely be on medical education. And the other way around is also to teach the doctors about AI. And as there's a famous quote that in the future, only people who have money to make technology, those people who build technology or those people who use the technology well will survive. So I'll translate that into AI. So it will be the doctors who are able to use the AI best would be something. It's not going to replace, but somebody who has a good skill in using AI would be helpful. So it should be incorporated in medical education, and it can really help out in many ways in terms of these lot of ways in which you can generate videos, in terms of simulations, and so many things can be done from AI. It will be very, very helpful.
Yes, doctor.
Yes, I was talking to some young interns the other day, and everybody now takes it for like second nature, that if there's a question, they can go on the internet and they can look up a drug and look at the side effects. But give it 20 years before, we were running around looking for the latest edition of for me was the British National Formulary to get the information, and even then, despite that, you could not hone it to that specific situation. But now the internet and connectivity, and that's all really has become part of the whole process. And I wondered if AI is also going to be suddenly going to creep up and do the same.
I just want to add, I think I can't comment on how it's going to change medical education, but I think Dr. Anurag brought up a really good point there about what we will be having is AI native practitioners, people who understand AI and understand how to use it, its drawbacks and advantages of it. And the outcome of that for someone like me is going to be that we'll have less fear. Today, there are a lot of people who fear AI because they don't understand AI, and they'll become more comfortable with it. And as Dr. Asrar already shared, some of the interns are comfortable with it. And that's going to have a huge impact for someone like me, because honestly, the work I do, as you saw from Dr. Anurag and Dr. Asrar's presentation, is that there are these algorithms, and these algorithms exist. We know how to use them. And it's all about just putting data into them and building them. What we need, that part isn't difficult. What we need is the expertise. We need people who understand that data, who are domain experts on that data, and it is these doctors. And so if you have doctors who are AI native people who understand AI and then who are also experts on data, they will help engineers build systems that are much better, systems that are much more scalable, and that can address many more problems.
Yeah. Dr. Shalabh Dikshit has asked, are there any specific models in the area of medicine or currently we are relying on the models available from different organizations? If there are specific models in the area of medicine, how are these models getting converged across the globe? So do we have medicine-specific models? Yes, Dr. Asra.
Yeah, maybe I could just answer it in my scope of practice. So sepsis is a really complex issue. And there are specific data sets that have been put together for engineers to apply their own models to that data set. And the data sets are given data sets. So what happens, you get a team of engineers, there'll be a competition, and the data set will be given. So the data set is given, but the models that they utilize can be tweaked and changed according to what's required. And as Dr. Anuraga said, the human in the loop is also an important development in terms of medical models as well. So I think the model side of things is flexible. But as I said, the important is the data. It's which data you use to understand the model, and which benchmark also that you see which model is good or bad against a certain benchmark.
And I think just to put forward in terms of data and the role of various societies coming up, we had a big challenge in 2017 from the Radiology Society of North America, who put forward around 8,000 X-rays with bone ages marked by experts. So they said, this is your development model, this is your validation model, and you use it, whatever technique you use, you create various ways in terms of developing. So now we have got at least a public resource of around 10,000 X-rays, which have got the marked bone ages by experts, which have been used to develop a lot of AI systems. So I think what's important is for the big societies to maybe come up with data, and that data can then be collated and used that way, because modeling will be different depending upon what is the best. And then there are at least 10, 15 people who participate in that competition. And this is the way forward, I think, from that regards.
From an engineering perspective, just want to add that the beauty of AI machine learning, why it has really taken off, is that we are able to build these models in a specific context, let's say identification of a car versus a bus, right? But the same concepts, the same underlying technology can then quickly be transferred over to make predictions on a different data set, which could be on an X-ray, is it positive or negative, right? So that's what's really helped expand AI so quickly, is where you're able to take these models that were built for one thing and then repurpose them for another use case. The other clear place where we see that there is new modeling coming out is with drug design. If you think about drug design, it is it's at a molecular level. Sorry. It's at a molecular level, and it is structured data, right? So it's similar to sentences. It's got grammar, and you can use the same principles that have been used to build something like ChatGPT, which is trained on English language, but then train it on molecular language and help do drug discovery and development much faster.
Yeah, in fact, that is supposed to reduce the cost for the pharma industry a lot. Some data that I read is for a new drug to be developed, the clinical trials, they spend close to $1 billion or more, and that is going to really be cut down. And Pfizer is one of the multinationals that is taking the lead, and they have invested in AI. Now, on to Dr. Diyari, I think there are a couple of questions regarding surgery. So if you could take those, robotic surgery and AI.
No, there is a question, or I don't know, just an explanation that maybe to my question, how to convince people to use AI or the patients. And it's written that it was like before open surgery and laparoscopic surgery. But open surgery and laparoscopic surgery is by the same guy who is doing. For example, I am doing, if I don't know the laparoscopy, I will open. If I don't know the open, I will do the laparoscopy. But this is two different issues, two different people doing this one. The AI, they are not a physician like us or instantly. So I don't know for that. The other question, I don't know also robotic surgery and AI, I did not get the point, what it means. Robotic surgery, what we are doing now, robotic surgery is different from AI. Maybe for the diagnosis, but as doing the surgery itself, I don't know how AI will do.
Maybe I can add
But
some color there. So I find that topic extremely interesting. And just for context, my dad's a urologist, and this is like a decade ago, back when I'm still in high school. He goes for a conference abroad, comes back, and I believe the machine name is Da Vinci for operating, right? And that's the big thing back then. And he's very excited, introduces it in his practice. And fast forward about a decade and a half later, I recently spoke to a startup here in San Diego, based out of my alma mater, UC San Diego, where now they're looking at how do we already have robots that can assist assist a doctor in doing the operation. How do we apply AI on top of these Da Vinci machines so that they can help direct the instrument without in a more precise manner? How they can help the doctor understand what trajectory they should move the needles or move the equipment so that they don't do any damage. Again, it's a human in the loop where the AI is making the suggestion on what the doctor should do, and it's again we are accounting on the doctor to make the best decision there. But that's some of the early things that we are seeing with AI and robotic surgery, and it's still new. It's a startup, so it's not anywhere where it's going to be deployed in hospitals as yet.
Till now, that's not there. But for example, for histopathology, for cytology, this is there. You will put it in the machine, and at the end, it will give you a report. It will give you the diagnosis. Although that's not according to the data what you are giving. For example, in malignancies, when they are diagnosing how many % of this is blast cell or how many of these are immature cells, that is still is going on. They are the machine learning or the AI still did not give you that answer. It will give you the malignancy, but the classification of the grading of malignancy still it is not to that. Yeah.
May I interrupt to ask one question? Change the topic a little bit. Now this AI system, this chat GP something is there. Now we have found the number of publication increased like anything. You just prepares one article for you in just few minutes, and there is no copyright because nobody can find from where you have got. And every day you can make one paper. So is it advantage or disadvantage? I mean, yes, Dr. Asra.
So my PhD has been now coming to the end, 3 years. I would say in the last year, my PhD has accelerated so much because ChatGPT came into the whole equation. Whereas before, it would take me ages to write the first sentence, the first paragraph. Now with it, you can at least get get some ideas, and you can get part of stage. So there's some great advantages of using it as an editing tool.
Yeah, but yours
Just
is
building on
genuine work,
papers.
and
No, this number of paper increase. Really, the quality also has increased. The research work in that, brain work in that. I mean, put or not, it just gives you ready-made. Suppose you want to make omelette yourself, a ready-made omelette come from sky. I mean, no, I mean, I think some disadvantage also is there. I don't know, in research.
Journals are now looking into ways in which they can detect the AI-based content. And so they will be, so these are things going to be, which are going to be screened very quickly and identified. Although some AI tools say that you can actually develop AI content which is not going to be detected as AI. So it's like a doping sort of a system in sports. People will go one step, they will pick up. So these sort of things will go up and down. But I think again, if you use ChatGPT as a model, what we are saying is that same as AI, we should use ChatGPT for the benefit, but that should not be the final word in terms of whatever is written there is going to be implemented. So it's going to help you out, but you have to be in the loop.
So if AI is a threat for humans, for the jobs, it's also creating jobs. Technology, programming, it is also giving opportunity for other subspecialties or specialties.
yes,
Sorry,
Dr. Asra.
I have a very important point to make. It used to take a PhD 3, 4, 5 years to build one structure of a protein. And 170,000 protein structures have been developed over the last 60 years. Now, I wanted to find out how much Google AlphaFold, how many proteins has it generated? It's written down here, 200 million proteins on AlphaFold. So it's just crazy.
There's a question
How
from.
safe is this system, Dr. Karpan? Sorry, I'm there.
No, no, it's
Like,
okay.
other systems which easily hacked. How safe and secure is this system since we are giving patients data? Can it be manipulated in order to get advantage by some?
So let me take a first shot at that, right? So it really depends on what system you're using. If you are using ChatGPT, I will first just tell you, stop putting your patient data on ChatGPT. It is not anonymized data. You're putting it out there. You're giving it to these systems, and you don't want to do that. What you would want to do is work with companies who are building special software for the medical field, because these companies are going to be regulated by laws in whichever country they operate. So if they operate in the US, you've got, I believe, the HIPAA laws, which prohibit how you deal with data, and they will build systems in place to protect the data. That being said, at the end of the day, when we're talking about storage of data, it is not an AI problem. The AI is just dealing with how to process the data and how to come up with an output using the data. The storage of the data is still your old school databases and security systems on top of that, and so they are just as vulnerable as any other system. The hope is that as we are dealing with people who are building for the medical space, they are thinking about these problems, and they are building, their engineers are building in the safety mechanisms to keep the data safe.
Thank you.
So there is one question by Dr. Anup Thomas on the use of AI for insurance payouts. So we have spoken a lot on the medical uses and details of that. Yes, Dr. Asrar, you can.
I was talking to 3M. So 3M, they control the DRG system. They're ones who have the intellectual property in the US and here. And the reason they have implemented and developed this other system is because they have shown that using their system of AI, they can increase the billing by 5%. And they actually then, in the assistance to the physician, they also then make sure that the right codes are being hit as well. So there is a potential impact on DRG and billing.
Right. And so this is one example of the, how AI will help the administrators also and the insurance companies. And so there are a lot of advantages of AI in healthcare system for the admins as well. So yeah, I think with that, we come to the end of this questions that have been posed by the audience. Dr. Asrar, would you just tell us in a nutshell, what do you think is the current stage? Like, what can a general pediatrician, what is our access to AI at the moment? Where are we?
I think there's probably, without realizing it, there's so many different applications and things are already available. Dr. Anurag has mentioned a number of things, but when you do the ECG, you see the output as well. You get the output. So, and as I mentioned, I've been now last few months using the Google Translator on AI. So there's so many different areas that it's already beginning to impact, and it's important to utilize those for patient benefit.
Sure. Dr. Anurag, actually, there were two questions asking about how do we choose an appropriate evidence-based app? So since you develop so many apps, let us know, how do we go about choosing one?
I think it's a very difficult one because it's at the moment a very unregulated industry. So we don't have, of course, any approvals which are there. Some of the patients app do require approvals and some get FDA approvals, which is, of course, a very tedious process which may not be followed by most scenarios. So I would say we should see what sort of publications were done from that particular app, and they will mention that there were some papers which are there, how many they were validated on, and go from there. I think in near future, we should also are the societies or things to review those apps. There are certain mechanisms in UK who review the apps and recommend for the physician that they are acceptable in that regards. But at the moment, these are early days. We don't have that many sort of resources available. And the ones which are really guiding practice, they need to be showing the evidence. It's like any intervention sort of a thing in that regard. But still remember that they are all there to guide. They are not going to be there to finally tell you that this is the final word on that regards here.
Sure. So I would request each of the panelists to give us a final message, starting with Dr. Asra.
The final message is, I guess, is that humanity is the only species that can build tools to increase intelligence. It can be used for good, and it can be used for bad. But as doctors, at least we should all try to, make sure we move things forward for the good of our patients.
Sure. Dr. Anurag.
I think I entirely agree, and the time has come that we should be there to understand AI and understand its implications. Whether we like it or not, in some form or the other, it's going to be a dominant force in future. The best thing is how we use it is something we should be prepared now. So this is the time for preparation, I would say.
Absolutely. Rachit, do you have anything more to add?
I think the disadvantages of going after Dr. Asrar and Anurag is that they covered it all. I'll just say that AI is, I think it's clear by the end of this that AI is here. It's here to stay, and our society is going to radically change over the next 5-10 years. And we need to make sure that we all understand what the changes are going to be and how we can be part of this change, and how do we steer this change for good. And so I'll hit back upon the earlier point I said. If there's one thing you do after this, is make sure you understand the concept of responsible AI. And in the future, when you deal with AI technology, you're thinking about those dimensions to make sure that you are using the best system for your patients.
Okay. Dr. Diari.
Thank you very much. Thank you for all the panelists,
Dr.
for the
Saurabh.
speakers, for Dr. Zorab and yourself, Dr. Kalpana. Thank you very much.
No, it is midnight in India. I don't know what time in San Diego. I would like to thank Dr. Anurag Vajpayee, Senior Consultant Pediatric Endocrinologist from Kanpur, India. Dr. Asar, Senior Consultant Pediatric Intensivist from Abu Dhabi. Our engineer Rachit Sengupta, Senior Software Engineer AI from Intuit San Diego, United States, Dr. Diari, Dr. Kalpana, Dr. Tawfiq for sponsoring our viewers. I would like to thank all viewers staying with us from all over the world, especially India, United States, and UAE. Thank you very much. We really enjoyed learning a lot, and good night. Thank you very much.
Good night. Thank you. Thank you. Thank you all.
Good night. Thanks to all of you. Thank you.